Welcome to the committee, Representative Bierman. House File 4347 is before us, and I will move the bill to Ways and Means. So, Representative Bierman, welcome to the committee, and please introduce your bill.
Thank you, Chair Cagle. Thank you, Chair O'Driscoll, for hearing this important bill today. Members, this is a straightforward clarification bill that closes an apparent loophole in an existing healthcare mandate on home care nursing services that has been law since 2010. It is not a new mandate and does not add costs to the commercial plans or to the state budget. When the legislature passed the 2010 law, the intent was very clear. For people on medical assistance who also have a commercial plan, the commercial plan is responsible for covering home care nursing services. Home care nursing is continuous, medically necessary care that keeps medically complex people with high needs out of the hospital and safely in their homes. The purpose of the mandate was to stop cost shifting onto the state and to keep this vulnerable population out of the hospital. For 15 years, commercial plans followed this mandate without issue. That changed this year. Two plans have reinterpreted the statute and capped home care nursing coverage to just 10 days per year for 2026. 10 days for a service that is medically necessary on an ongoing basis. This is a dramatic departure from long-standing practice and from the legislature's original intent. In recent discussions, the plans have said that the 2010 law doesn't say that they cannot cap coverage and that they actually have just been covering these services out of their own goodwill for 15 years, not because they thought they were required to. The plans have said they applied these caps because they want these families to move to medical assistance. That is the problem here, and the exact opposite of the 2010 mandate's cost-sharing intent. Shifting this care onto Medicaid means families lose their waiver budgets and access to therapies that traditional Medicaid does not cover. Providers take a rate cut. The home care nursing workforce shortage worsens. Families lose their nurse staffing consistency, and the state Medicaid budget absorbs the full cost of care. Members, this is important for you to understand. If we do not pass this clarification and close this loophole this year, this reinterpretation will shift millions of dollars onto the state budget. Not just the home care nursing costs, but the total cost of care, hospitalizations, medications, enteral nutrition, all of it. Many families choose commercial insurance specifically for the reliable nursing hours. With only 10 days of coverage, there is no incentive to keep commercial insurance at all, and the state will be on the hook, and the plans off the hook for the total cost of care. For the 200 to 250 people in this category, annual care costs range from $300,000 to $1 million. If the commercial plans no longer wanted to cover this care, they should have come to the legislature with a bill to change it. The health plans are not lawmakers and cannot unilaterally decide who pays for this care when there is existing law already dictating that. Their decision caused harm and wasted countless hours of families' time as they were left to figure this change out on their own. In the 2010 House Health Committee hearing where this provision was discussed, Representative Huntley said, "These people who are eligible for medical assistance but have health insurance through their family, the health insurance would have to cover the cost of nursing, and the state would not pay medical assistance for that service." Members, the intent was crystal clear. The 2010 mandate was a deliberate choice by lawmakers. The commercial plans, not medical assistance, would cover medically necessary home care nursing, care needed on day 1 and on days 11 through 365. This is not a complicated bill. It is a simple clarification of the legislative intent and maintains the last 15 years of practice. I ask for the committee's support, and we have testifiers here today who could speak to the negative impacts of such a drastic coverage cap. If we could go to testifiers, please, Madam Chair.
Thank you, Chair Bierman. And so first up, we have Brandon Walters, followed by Catherine Chambers. Nice to see you again. Welcome to the committee. Please state your name for the record and proceed with your testimony.
Yes, thank you, Madam Chair, and members of the committee. My name is Brandon Walter, and I am here from Medina, Minnesota. I'm here today to support HF 4347 for my medically complex son, my family, and so many other medically complex families in the state of Minnesota. I had my full testimony prepared for today, but last night I received a call from a mother of a medically complex child who was in absolute panic. Her home care nursing agency had just informed her yesterday that her 120 visit cap imposed by Health Partners had not only been reached, but been exceeded. And they were calling to ask how she planned to pay for the services keeping her daughter alive. I'm sorry. I'd like to rewind for a moment. This family received an approval letter from Health Partners in December of 2025, stating that their daughter was covered for the entire 2026 calendar year for home care nursing. Then, on January 19th, just 4 days after open enrollment ended, they received a second letter saying Health Partners would now cover only 120 visits for the entire year, a tiny fraction of what their daughter is prescribed. These health plan companies have told us, and they'll probably tell you today, that they've notified all county case managers. Well, I can tell you, I have spoken personally to many of those county case managers throughout different counties, and none of them have heard from Medica or Health Partners regarding this issue. This is the real consequences of an arbitrary limit imposed by a commercial insurer that has known for 15 years exactly what Minnesota State Statute 62Q.545 requires. This statute acts as a load-bearing Jenga block. If you pull it out, the entire medically complex community collapses. Families financially devastated, parents forced out of the workforce, children pushed into hospitals because they cannot safely remain at home any longer. This is not theoretical. It is happening right now and will continue to happen to these families one by one. This needs to be stopped immediately. Please pass HF 4347, keep these kids at home, keep them out of hospitals, and stop insurers from dismantling a mandate that has protected medically complex children for more than a decade. Thank you.
Welcome to the committee. Please state your name for the record and proceed with your testimony.
Hi, my name is Kit Chambers, and I live in Plymouth, Minnesota. I'm here today with my son Nash and his nurse Maddie in support of HF 4347. This bill matters to my family because Nash has both private insurance and medical assistance. We use the Community Alternative Care Waiver, CAC waiver, through the Consumer Directed Community Sports, CDCS. This option helps Nash live and thrive in our community rather than the hospital, where he spent the first 476 days of his life. During that 15-month hospital stay, I dreamed of what life would be like outside the 4th floor NICU. I knew that given the chance, Nash would thrive at home, and I did not expect that fighting for this dream would bring me here today, talking to all of you. I chose this path of private insurance and medical assistance so Nash could get the care he needs in our community, so we could pay our nurses a competitive wage without exhausting our waiver budget. Right now, the way nursing is paid creates serious problems for families like ours. Private insurance pays first, then medical assistance, and then the waiver can only cover authorized services. If any part of that care is denied, capped, or not fully covered, the the cost can fall back on my family directly or onto the waiver budget, which is not designed to absorb nursing hours. If nursing hours are shifted onto the waiver, Nash loses services that are vital to his quality of life, like music therapy, massage therapy, pool therapy, and our much-needed respite care. And beyond that, the hours I'm paid to cover the gaps in his 24-hour, 365 days a year care when nursing agencies are unavailable. The supports that hold up this system, private insurance, medical assistance, and the waiver, are becoming increasingly fragile, and that creates instability for essential, ongoing nursing care. For Nash, nursing is not optional. It allows him to go to school, receive therapies, attend medical appointments, and remain safely at home. I'm also paid through Nash's waiver for some of his care, which means I know firsthand that caregiving is not a path to wealth. It is hard work, and it comes with a sacrifice. Families like ours live in constant awareness that anything can change in a moment, especially as we've watched our children fight to breathe and to exist in this world. We're familiar with fear, often oscillating between gratitude and grief. Is there any data that shows nursing limit caps, improve patient care, or reduce harm for medically fragile children or their families? I urge you to support HF 4347 to stop this coverage cap before it causes lasting harm to families like mine. Thank you for your time and the work you do on behalf of all Minnesota families.
Thank you. Next up is Cameo Zander, followed by Chelsea Olson. Good morning. Welcome to the committee. Please state your name for the record and proceed.
Thank you. Good morning, Madam Chair, Mr. Chair, and members of the committee. My name is Cameo Zender, and I'm with Pediatric Home Service. I wanted to briefly provide some perspective through the provider lens. Home care nursing for medically complex children is hospital-level care delivered in the home environment. In order to safely care for these children, agencies like ours must recruit and retain highly skilled nurses trained to manage ventilators, complex medications, and very quickly changing conditions of these children. To do that, we rely on the commercial insurance rates, which are higher than the Medicaid rate and mutually agreed upon between the health plan and the provider. These rates allow us to pay that competitive wage similar to what a nurse can earn in the hospital environment. If this is allowed to continue, we will have no choice but to reduce nurse wages to Medicaid levels. And when that happens, nurses leave home care. We are already in a critical workforce shortage. A study conducted in the state of Minnesota showed that medically complex children remained in the hospital on average 54 days past the date they were medically ready to go home, solely because of lack of access to home care nursing. We understand that healthcare is complicated. We understand that if this continues, access will shrink. Families will lose care, children will remain in the hospital or be pushed into institutional settings, and hundreds of millions of dollars will transfer to the state. Like I said, healthcare is complicated. This bill is not. We urgently ask for your support of House File 4347 to clarify and confirm the legislative intent as it was established in 2010. Thank you very much.
Thank you. Up next is Chelsea Olson. Welcome to the committee. Please state your name for the record and proceed.
Madam Chair, members of the committee, I am Chelsea Olson with the Minnesota Council of Health Plans. Thank you for the opportunity to testify on House File 4347, and thanks to those who shared their stories today. We want to let you know that we hear you and that our member plans are committed to finding a solution that ensures families get the care that they need. As we talked about in this committee earlier in session, there are already significant cost challenges in the individual market due to rising healthcare costs. These high costs have resulted in significant losses for carriers, fewer plan options in some counties, the insolvency of UCare, and premium increases. The current products in the market were reviewed and approved by Commerce and include limitations on home health care services. Chair Bierman mentioned the high cost of these home health care services. With the bill as written, we are concerned that removing all limitations on commercial coverage will make it difficult to keep premiums from rising even further and maintain access to care. We are meeting with stakeholders, and we will be constructive in working to find a solution to maintain access to these important services. Thank you.
Thank you. Next up, we have Kelly Wolf, followed by Barbara Cox. And Ms. Cameo, if you want to go back to the audience, if there's any questions, we can call you back up. Oh, go ahead.
No. I'm sorry, were you talking to me?
No, I'm, Ms. Zender, if you want to go back to the audience, and then if there's any questions, we can
Oh.
call you back up.
Very good.
Thank you. Welcome to the committee, Ms. Wolf. Please state your name for the record and proceed with your testimony.
Great, thank you. Madam Chair, members of the committee, my name is Kelly Wolf, and I'm the Senior Director of Government Relations at Medica. We are a nonprofit health plan that currently serves more than 1.4 million people in Minnesota and across the Midwest. Thank you for the opportunity to share some thoughts today regarding House File 4347. First, let me say we do fully recognize the importance that home nursing services are for children with complex medical conditions, and we do share the goal of ensuring that those children continue to receive the care that they need. In the fall of 2024, we made a decision to reevaluate the administration of extended home health benefits for individuals who were also enrolled in the medical assistance program beginning in 2026. We did that with the understanding that Medicaid would continue to provide the nursing services that these children qualify for. Medicaid provides the most comprehensive benefit set of any type of insurance, including the lowest cost to the patient due to limited cost sharing. In fact, nearly 70% of home care nationally, including private duty home nursing, is paid for by Medicaid, which has historically been the provider of comprehensive medical services, particularly for children with disabilities and chronic conditions. Medicaid also provides a level of consistency that private insurance plans sometimes cannot, or employer-sponsored insurance that could change due to employment transitions or other life events. As the safety net program providing coverage to children with disabilities, Medicaid is often most suitable in those circumstances. Our state has created a system to help support these families with a combination of comprehensive Medicaid services and various waiver programs. The Medicaid waivers are designed to cover extended services such as private duty home nursing care. If there is an issue with families accessing their waivers, insufficient waiver funds, or the definition of authorized services and what can be covered, then we are open to exploring those solutions. We do share the goal of ensuring that these children and families continue to receive the care that they need, and we are open to conversations to explore some of those alternatives. We do have a scheduled meeting in the next couple of weeks with the advocates and with DHS to talk through some of those solutions. Again, we remain hopeful that we can come to an agreement that allows these families continuity of coverage and care.
Thank you. Ms. Cox, state your name for the record and proceed. Thank you.
Good morning, Madam Chair, members of the committee. My name is Barbara Cox. I'm here testifying on behalf of Health Partners. We also hear the committee's deep concern for families with needs for intensive home health services for their children with complex health needs. We want to work with policymakers, DHS, and counties, and are also engaged in the upcoming meeting to do so that families can have a smooth transition to services and medical assistance when they reach their coverage limits in commercial plans. In the case of Health Partners, the limits we have in our coverage we have had in our policies since 2014. We also support increased benefit levels for these members of medical assistance to further support these families should the legislature choose to increase those benefits, as well as provider pay in order to address some of the concerns related to the waiver. The legislature could raise the reimbursement rate for providers for this subset of enrollees to commercial levels in Medicaid. Thank you for the opportunity to share our perspective.
Well, I have you both up there. I have a few questions, please. So, from my understanding, Medicaid actually Medica actually told patients prior that they were not going to cover these services, correct?
So we made the decision in November of 2024, after an annual review of our benefits and compliance with state laws and regulations. We consulted with our regulators to ensure that our interpretation was correct. And in May of 2025, we sent our first letter to county case managers as well as to families that the plans would be changing as of January 2026. So we did provide advance notice, offer case management services, worked with families to address their questions and make sure that they could have the information that they needed for the upcoming year. And then we again provided notice to families in August, just to, again, make sure that they were receiving the information that they needed and to help them through that transition.
Thank you. Ms. Cox, when did you guys make your clients aware of that this coverage was no longer going to be available?
Thank you, Madam Chair. In the case of Health Partners, we let members know earlier this year that we would no longer be granting exceptions to the coverage limits. So while the coverage that members signed up for did not change, the coverage has been the same. In the past, we had a practice of granting exceptions to those limits, and we notified members that we were no longer able to do so earlier this year.
Was that before or after open enrollment closed?
Thank you, Madam Chair. It was after open enrollment closed.
So people signed up for plans thinking they were getting services, and then after open enrollment closed, you told them they no longer could get those services. Did you refund them their money for their premiums?
Madam Chair, thank you for the question. I am not aware of all of the details of our members' cases, and there's some data privacy rules that relate to those. But in the case, generally speaking, because members are getting the visits in their coverage and the exception was beyond the coverage limits that were in the policies, I don't believe so.
Thank you. So, Ms. Wolf, do you think when you notified your clients that they would not have coverage, that they probably sought coverage elsewhere?
Madam Chair, since we provided notice to families in May, I think that we thought two things would happen. One, that during that open enrollment period, that they would continue to look for other plans that covered those benefits or provided a benefit plan that best suited their needs, or they would utilize Medicaid, since these nursing services are covered through the Medicaid program in addition to waivers. So it was never our intent that families would not have coverage. We made the decision that we did, knowing that we have a system in place through Medicaid and through the use of waivers that these families could access, and we tried to help them through that transition, working with their county case managers. So we felt the time, which is why we gave them some advance notice to make those plans several months in advance.
Thank you. Are there any other questions for these testifiers? Representative O'Driscoll.
Just very quickly, Madam
Chair
Chair, I want to
O'Driscoll.
clarify with both of the representatives from Health Partners and from Medica. Ms. Wolf, I want to just make sure you had indicated that in consultation with your regulator that you had made this decision. Who's the regulator that you consulted with?
Ms. Wolf?
Madam Chair, Representative, we spoke with both DHS and the Department of Commerce when making this determination.
Madam Chair. Ms. Cox, same question to you.
I am not aware of working with regulators related to our practice. Regulators, go through the process of approving our products. So because this was a change not in policy, coverage policy, just in the practice of granting these exceptions, I'm not aware if we sought approval from regulators.
One
Chair
other follow-up
O'Driscoll.
question for Ms. Wolf. When you consulted with the regulators, did they give you any indication that these policies had been rated in such a way that it did include this benefit, or did they agree with your interpretation that you maybe have gone beyond what the policy limits have had, and that in fact the department didn't approve these with that type of coverage in there?
Ms. Was that to Ms. Cox or to Ms.? Oh,
Ms. Wolf.
Ms. Wolf, sorry.
Yes, Madam Chair, Representative, thank you. Yes, now, to be clear, I wasn't in those conversations, so I can't speak to the details, but I do know that we were providing a benefit that we felt far exceeded what the state law required, brought that inquiry to those regulators, and they agreed with our assessment, which is why we decided to move forward.
Thank you, Madam Chair.
Thank you. And we do have Commerce here as well. So up next is Sam Smith from the Commerce Department. Welcome to the committee. State your name for the record and proceed.
Chairs Cagle and O'Driscoll, members of the committee, my name is Sam Smith, and I'm here to testify on House File 4347 on behalf of the Department of Commerce. I'd like to begin by acknowledging the challenges that many Minnesota families are experiencing regarding changes in how private insurance is administering home care nursing services. While medical assistance is available for these families to wrap around or supplement a major medical plan, this change can force tough choices with limited medical assistance budgets. The Department of Commerce is aware of these challenges, and our enforcement team has been responding to complaints in this space. While we are unable to comment on open investigations, I can share that some have concluded and others are ongoing. The Department of Commerce is neutral on this proposed bill and only notes that this is a complicated issue with no easy answers. We appreciate the work being done in this committee to respond to meaningful constituent concerns and to think through the interactions between private insurance and medical assistance. Thank you for your time, and we're happy to answer any member questions.
Thank you, Mr. Smith. That is it for the testifiers on the list. Is there anybody from the public wishing to testify? Going once, going twice. Testifying is closed. All right, Representative Hewitt.
Thank you, Madam Chair, and thank you, Representative Bierman, as I am also a co-author on this bill. First of all, I must say that I have a past in this in my previous life of dealing with these type of patients, from bringing them home for the first time to bringing them, unfortunately, back to the hospital. The heroes in this really are the parents. When you go into these homes or bring the kids home, the parents know the care. They know if it's not a specialty ambulance, we need the parents to go into the hospital because they know the equipment, they know the patient, and they know what's best. But one of the things, and this really took place back in the early 90s when I was still on the ambulance, and we figured that it was best to have the patient return home to their own community. So we were taking these patients from Moore Road down to Wells, across the whole state. And that's what's actually kind of neat, is that we knew that the outcome for the family and the outcome for the patient was better in their home communities. And where I'm having some issues with this today is that, and I get it, the payers have to make sure that they have their margins, but this is where we as the state partner with the payers and look at some of the things we do together to make sure that, a patient that lives in Wells can go home, can have the same care level as somebody that lives in Apple Valley, but yet also have the ability to come back if they need to. And I think this is where we really do have to lean on the payers here a little bit to make sure that this happens. We give them breaks in other areas. Sometimes they don't feel that, but I think that this is really an important subject, because we know that when you bring somebody to their home and their family is able to be united, that the patient and the family do much better. So I first, like I said, I want to call out the parents. They are like, I just can't believe it. They are so great. They've taken this, it wasn't probably their choice, but they've taken this on, and they're just wonderful people. They're the neatest people in the world to meet, but also the providers, they're there. We saw one in the room today here, and this is really a special forum, and I'm glad we can keep providing this, and I'm hoping we can come to an agreement, or if we can get this bill through today. Thank you, Chair, for letting me make the statement here.
Thank you. Representative Finke?
Thank you, Madam Chair. Thank you, Representative Bierman, for your bill. I just want to get a clear understanding, and perhaps one of the testifiers can answer this. I'm not sure whom, but this seems like a question of continuity of care, right? We have care that is currently being provided to families who need care, and we appear to be at risk of having that care interrupted. Is that correct?
Representative Bierman.
Yes, Representative Finke, that is exactly correct.
Representative, thank you.
Thank you very much, Chair. Excuse me.
Sorry, and
No, you're
I may add, interruption is probably not an adequate word.
Yeah.
It's crumbling.
So I guess my question is to perhaps Commerce or one of the insurance lobbyists. What happens to the care? Like, if we don't pass this, what happens to these families? Just explicitly, like, do they lose their coverage?
Maybe one of the
Miss-
families? Ms. Chambers?
Hello again. Specific to us, because my only way of getting paid is through Nash's waiver, it all goes away. If it's capped at 120 visits, best case scenario, Medica or medical assistance matches, but they could approve 0. And there's a chance that 120 or 240 days into the year, care goes completely away. And that leaves us in September, where instead of going to school 3 days a week, my son will have me. And I won't be getting paid because it will be all gone. Thank you.
Representative Finke?
Thank you very much, Chair. I appreciate the time, and I appreciate you coming and bringing your family and sharing this experience. I don't know what we're doing if we take healthcare away from people who need healthcare. Like, what's the point of being a legislature if we aren't going to help people have access to care they currently have? And with respect to the testifier, healthcare coverage, saying that coverage is the same as when you enrolled, except for now there are new exceptions, is not the same coverage. It's different healthcare coverage. So we shouldn't assume that nothing has changed when something is clearly changing. And it's families who need care that are going to be at risk. So the point of all of the work that we do is to help people, and this seems to me like a way to help people. Thank you.
Thank you, Representative Finke.
Thank you.
Chair O'Driscoll?
Thank you, Madam Chair. If Mr. Smith could return to the testifying table, please.
Welcome. Chair O'Driscoll?
Thank you, Madam Chair. Mr. Smith, I just want to pursue the line of questioning I had with the two representatives from Medica and Health Partners. Does the department, when they review policy forms every year and approve rates and like, what was the department's interpretation of this provision? Was it as it had been customarily done, or is it something that is the insurance companies had been doing, but now are choosing not to do within the policy form? Just trying to get clarification why for 15 or 16 years this hasn't been an issue and now it is, and what's the enforcement division of the department looking at doing with this?
Mr. Smith?
Chair Cagle, Chair O'Driscoll, thank you for the question. Well, the department can't speak to coverage choices made by the plans. What I can say is that when we are making enforcement decisions, it would depend on the particular facts and circumstances of any particular change to coverage limits. However, the department does not see anything in 62Q545 that prevents a health plan from placing limitations on its coverage of home care nursing services in its insurance contract.
Chair O'Driscoll?
Yeah, very quickly, Mr. Smith, so then the department didn't explicitly approve these forms with this coverage in there, is that correct?
Mr. Smith?
Chair Cagle, Chair O'Driscoll, out of an abundance of caution, I'll say that I'm not exactly sure on that, and so I'll have to get back to you.
Chair O'Driscoll?
Thank you, Madam Chair.
Thank you. So this issue is actually really personal to me. 5 years ago on April 6th, my niece Isabel passed away. She was 18. She had a very, it was hard. The emotional toll that these families are going through in limbo right now, I can't tell you how many families I've talked to, and it all ends in tears. I feel like this was super deceptive. handcuffing people into these plans to only tell them 4 days after open enrollment ended that they weren't going to have access to these services. The people who take care of these children, it's their life. It consumes them 24 hours a day. Cleaning tubes, getting feedings ready, making sure that they're in the standing chairs so that they can get the exercise they need, physical therapy. It's a constant schedule of bringing these kids back and forth to appointments, to therapies, and then the parents are often exhausted and at the end of their ropes. I've seen it personally. I've seen the toll this takes on families. And putting more pressure on these families when all they're trying to do is take care of their kids is absolutely ridiculous. And if Commerce isn't interpreting, or if Commerce can't do anything about this, we can. That's our job. And if we really care about families and kids and, we need to do this. It was deceptive, it was wrong, and the family should not be suffering because of it. Representative Bierman, Chair Bierman, to your bill.
Are we final comments? then?
Yes, please.
Okay. Final comments. First off, I want to thank the families who have come this morning and told us their stories and the hardships that are out there for them. I want members to consider that Minnesota created a system in 2010 specifically for the insurers to be the first payer for home care nursing. And it is a system that the insurance companies have decided to change. The system was created in 2010. Some policy was changed at one of the providers in 2014. They granted exceptions, which to me means they followed the law. So I think it's very important that this committee move this bill forward, pass this bill, and the talk about a summit to come up with better ideas to handle this situation can still go forward as well. But in the meantime, let's let the law from 2010 stand until we decide to make a change to it. And I have no doubt that we can make a better system. But this is one small part of a healthcare system that we have massive work to do across the spectrum of our healthcare. And this is a small part, but a very important part. And it is not acceptable for the legislature not to act now and to kick this can down the road and create the hardships you're hearing. That will throw millions of dollars onto the state immediately. And that is not the intent of our current law. So we need to change that together. And I am more than happy to meet with plans, providers, and families to figure out better ways to do this. But first, we need to stable and right the ship. So thank you very much. I appreciate the committee's attention and ask for your vote to support this bill to move forward. Thank you.
Thank you.
Madam Chair,
Representative Katiza Mattoon.
I'd like to request a roll call.
Roll call being requested. All right, so I move that House File 4347 be referred to the Committee on Ways and Means. The clerk will take the roll.
Co-Chair Cagle.
Aye.
Cagle, aye. Co-Chair O'Driscoll. No. O'Driscoll, nay. Co-Vice Chair Elkins.
Aye.
Elkins, aye. Co-Vice Chair Perryman.
No.
Perryman, nay. Representative Allen.
No.
Allen, nay. Representative Buck excused. Representative Cha.
Aye.
Cha, aye. Representative Davids.
No.
Davids, nay. Representative Dotseth.
Nay.
Dotseth, nay. Representative Falconer.
Aye.
Falconer, aye. Representative Finke.
Aye.
Finke, aye. Representative Hansen.
Aye.
Hansen, aye. Representative Heinzman.
No.
Heinzman, nay. Representative Hewitt.
Aye.
Hewitt, aye. Representative Katiza Wattoon.
Aye.
Katiza Wattoon, aye. Representative Kresha.
No.
Kresha, nay. Representative Reimer.
No.
Reimer, nay. Representative Smith.
Aye.
Smith, aye. Representative Van Binsbergen.
No.
Van Binsbergen, nay. Representative West.
No.
West, nay. Madam Chair, there are 9 ayes and 10 nays.
Being 9 ayes and 10 nays, the motion does not prevail. I'm sorry.